Well, good afternoon, everyone, and welcome to the first quarterly Ending the HIV Epidemic, which we call EHE, Stakeholder webinar. I'm Admiral Brett Giroir, the Assistant Secretary for Health and the HHS lead for diagnostic testing efforts for COVID. These past months have been incredibly challenging and stressful for all of us. Everyone should take pride in the fact that the Department of Health and Human Services is working around the clock responding to this pandemic. Our colleagues, particularly our public health service officers, are working on the front lines, and many are supporting state and local governments, healthcare providers, in nursing homes, and in communities that are disproportionately impacted by COVID-19. We are so grateful for all of their work and for so many of you who have put in so much for this fight already. Despite the COVID-19 pandemic, which is historic in its proportions and impact, I wanted to take this opportunity to emphasize that ending the HIV epidemic initiative is still a vital administration priority. When President Trump announced the EHE in his 2019 State of the Union address, he recognized, quote, "We have a once-in-a-generation opportunity to end the HIV epidemic in the United States. Now is the time," unquote. And I want to reaffirm that HIV, ending this epidemic, continues to be a top priority, not only for me, I think it's obvious that it is for me, but also to Secretary Azar, who is himself firmly committed to this and embraced it from the moment we brought it to him. Today you will hear from my federal colleagues on the work conducted to end the epidemic in America and our progress to date. We will continue to face tremendous challenges from COVID-19. It is not going away anytime soon. So it is critical to continue implementing EHE and truly double down on our efforts to reach communities who face multiple risks. But make no mistake, our challenge to end the HIV epidemic just got immeasurably harder and more complex due to COVID-19, due to the massive disruption of our healthcare system, the loss of insurance for tens of millions of Americans, compounded by unemployment and burgeoning behavioral and mental health concerns, all of which are risk factors for worsening the HIV epidemic. We will continue to monitor the COVID-19 response and continually reassess the situation as needed. But we continue on with our programs. The nationwide Ready, Set, Prep program continues providing PrEP medications at no cost to individuals who qualify. It raises awareness about PrEP, reducing new HIV infections, and bringing the nation one step closer to ending the epidemic. Despite all the problems and challenges COVID has brought, it has also raised some new opportunities. For example, we are now intensively using telemedicine for medical appointments for those living with HIV, and teleprep consultations for those raised every American's awareness of the significant health disparities that have plagued our nations for decades and which have exacerbated our health disparities in HIV. We're committed to address these disparities, and I think the whole of our country has new understanding and empathy. I think there'll be a new commitment to end these disparities forever. So thanks to all of you who have joined us for this inaugural webinar and for your committed service to all Americans. I know today's presentations will help lead us to important, truly concrete steps to end the HIV epidemic in America. Thank you for allowing me to spend a few moments with you at the start of this webinar.
Thank you, Admiral Giroir, for the opening comments. Everyone, welcome to our first EHE quarterly stakeholder webinar. As Admiral Giroir said, this is the initial call, but we are looking to have these every quarter to provide updates on our progress in ending the HIV epidemic and share a little bit about what we're doing, but also in the future, we hope it provides an opportunity to hear from jurisdictions about some of the innovative approaches they've been doing, as well as how they've risen to meet different challenges. My name is Harold Phillips, and I serve as the Chief Operating Officer for the Ending the HIV Epidemic Initiative in the Office of Infectious Disease Policy in OASH, in the Office of the Assistant Secretary. Welcome to the webinar. We want to remind you that this webinar is being recorded, and we're pleased that so many of you have joined us for this opportunity. At last report, there were over 2,000 participants who signed up for this webinar today. We appreciate the time and consideration of all of you all for joining us, and we hope to provide important updates on the initiative itself. As a reminder, this webinar is not a press event. With that in mind, this is an opportunity for a wide range of stakeholders to highlight the administration's continued commitment to ending the HIV epidemic. You'll hear from several of my federal colleagues about the work that has taken place over these last few months. We'll also highlight major HHS activities to date and plans for implementing the EHE, the Ending the HIV Epidemic Initiative. We'll also leave time for questions and answers from you all who've joined us today. Next slide. And the next one. So you've already heard from Admiral Giroir. You'll hear from the federal leads who will provide progress updates on the initiative and moving forward. We'll also have time for questions and answers. I'll serve as the moderator for that session with help from our staff as well. Next slide. Okay, well, next we will hear from Rita Harcrow, the Director of the Office of HIV/AIDS Housing at HUD. She'll provide updates on EHE and the work that HUD and HOPWA program have been doing in collaboration with our federal colleagues. You'll also hear from Rear Admiral Jonathan Merman at CDC, who will talk about some of their work, and Dr. Laura Cheever from HAB, the HIV/AIDS Bureau at HRSA, as well as Jim McCrae from the Bureau of Primary Health Care at HRSA. Rear Admiral Michael Todt from IHS, Indian Health Services, Carl Diefenbach from NIH, and Dr. Kirk James from SAMHSA. So we've got a full house with many speakers who are ready to provide you with updates on everything that's been going on as we move EHE forward. Next slide. Please remember the audio is being shared via your computer, speaker, or headset. If you can't hear the audio, make sure your computer audio is turned on and the volume is turned up. Click the, I call it the hat, next to audio settings to change your speaker. If you are still having audio issues, please send us a message in the chat box and someone will attempt to assist you. Next slide. When we get to the Q&A portion of the session, to ask a question about logistics, audio, or visual issues, please use the chat box. Click on the chat icon in your bottom toolbar to use it. To ask a question about content for the Q&A section of the webinar, please use the Q&A box. Click on the Q&A icon in the bottom toolbar to use it. So we've got a separate chat for logistics and a separate one for content. Next slide. Just briefly, our agencies and our providers who are serving people at risk and with HIV have experienced a number of challenges, as Admiral Giroir talked about in his opening statement. We've had everything from lockdowns that have deterred people from seeking testing or PrEP, from going to their regular appointments, clinic closures or change or restricted hours. We've battled limited stock of basic supplies like PPEs, and we are experiencing clients losing their jobs in health insurance. Ambassador Birx at IAS last week said that nothing stops an HIV program. All across this country, programs have adopted and implemented innovative approaches everything from mailing HIV rapid self-test and home collection specimen kits to clients to ensure people are still getting tested, to scaling up telemedicine quickly and using video and phone so that patients can meet with their providers to get on and stay on HIV treatment. And following CDC's PrEP guidance, providers are prescribing, when appropriate, a 90-day supply of PrEP medication to minimize trips to the pharmacy and to facilitate PrEP adherence. Some of these innovations may become more permanent parts of our nation's ongoing HIV response to help us achieve our national goals. And I know that several of our federal colleagues are looking into this, but you are probably also thinking about this on the local level. So, and we thank you for that innovation, and we thank you for your continued commitment to serving the community. Next slide. And now we'll hear from Rita Harcrow, the Director of the Office of HIV Housing in the Department of Housing and Urban Development at HUD. Rita, are you ready?
I'm ready. Thanks, Harold.
Right.
Thank you. Go back to the previous slide. Oh, we're missing one. Go ahead, then forward to the next. I'm Rita Harcrow. I'm the Director of the Office of HIV/AIDS Housing at HUD. That's the office that administers the HOPWA program. And first I want to say thank you to OIDP and all our federal partners at Department of Health and Human Services for allowing my office to join the discussion about how housing can and should be part of EHE planning efforts. I believe that our country cannot end the HIV epidemic without housing. In August, OHH began coordinating with our HHS partners on the EHE initiative. From the early conversations with our federal partners, as well as local community leaders, it was clear that HUD needed to get information about HOPWA into the hands of our local planners. My office has been working to develop a resource tool that matches HOPWA resources with EHE Phase 1 jurisdictions. This information helps identify how the HOPWA program intersects with EHE. The resource tool lists the HOPWA formula and competitive grants programs in EHE Phase 1 jurisdictions, along with data elements on key variables like client access to care, the amount of HOPWA money spent on supportive services in a grant area, and the amount of the HOPWA grant spent on housing activities for HOPWA clients. And here you see a screenshot of the primary tab of the HOPWA EHE tool. The HOPWA resource tool has community-specific info for the EHE planners, and that information lists HOPWA formula modernization funding projections for each formula grant within the jurisdiction, as well as contact information for both HOPWA grantees and their EHE counterparts. Next slide. So more recently, in February, a final version of the EHE resource tool was approved. In March, our office distributed a condensed version of that tool individualized to every HOPWA grantee that was also an EHE Phase 1 jurisdiction. Following that distribution of information, OHH conducted a webinar along with our OIDP partners to demonstrate the resource tool for the HOPWA grantees and our HUD field offices. So we started with that. Then our timeline for rolling out this tool has been necessarily delayed as we've all been impacted by the COVID-19 pandemic. But now that we have that tool developed, we're able to update it and we'll be able to provide relevant data changes as they occur. So even though we're slightly delayed in our plans, later this month on July 23rd, our office in coordination with OIDP will be presenting a webinar demonstrating the HOPWA resource tool for EHE Phase 1 jurisdictions and stakeholders in that area. And we're pleased to see that rolling out this month. And now I'll turn the presentation over to the CDC's Rear Admiral, Dr. Jonathan Merman. Jono?
Great, thank you very much. And thank you, Harold and Admiral Giroir, for inviting me. Good afternoon. I will touch on two areas in the next 3 minutes. One is highlighting some new data on the HIV epidemic in the country. And the second is to how we are adapting in the time of COVID-19. So CDC is committed to ending the epidemic as quickly as possible and reducing HIV disparities while we decrease incidence overall. And our recently released HIV surveillance report shows some areas of improvement and some worsening disparities. Overall, after several years of lowering incidence, there was a non-significant decline in new HIV infections from 2014 to 2018, from 38,100 to 36,400. In addition, there was a 31% decrease of HIV infections among men who have sex with men aged 13 to 24 years, with a particularly large reduction among young African-American MSM, a population that used to have the highest incidence of HIV infection. There was also a large decrease in HIV incidence among African-American heterosexual men and women. However, there's been a shift to increasing rates among persons aged 25 to 34 years. And there's continued disparity with MSM and transgender persons who have an incidence of HIV more than 100 times cisgender men and women. And they account for 70% of all new infections. There have been major disruptions of HIV systems due to C19, community-based organizations, syringe service programs, and others have had to reduce services or close their doors over the past few months. Health department staff, including disease intervention specialists, have been shifted to COVID-19 work. And the reductions in visits to emergency departments and clinics have reduced the number of people who receive routine HIV screening and testing over time. We've reached out to our grantees to provide status updates on the disruptions that they're facing so we can work to mitigate those as much as possible, including being flexible about administrative actions, to track issues with data, and we're providing ongoing support via webinars and virtual technical assistance and by issuing some program guidance. We are supporting adaptation to this changed environment by exploring creative ways to advance the important efforts of EHE, and we're receiving great ideas from the field that we can sometimes amplify and share with others. We continue to focus resources where they're most needed, including African American, Latinx, and Native populations who are so deeply affected by HIV and C19. And we have released recommendations and are encouraging expansion of HIV self-testing strategies, including providing new resources to conduct mass internet-based mailing of HIV self-tests focused on the people who need the testing the most. And we've also provided new guidance on providing PrEP and diagnosing and treating STDs during this time when in-person clinical care has been reduced. We've been working in partnership with HRSA and HHS, and we received and provided feedback on all of the jurisdictional EHE plans this spring. And on August 1st, we will be providing funding to all EHE jurisdictions so that they can begin implementing the CDC-supported components of their ending the epidemic plans. And for many of us, fighting for public health and justice are the reasons we entered the HIV world. And with C19, we have new challenges as well as strong prevention tools such as testing, safer ART, and PrEP. And using these along with science and empathy and ingenuity will bring us closer to ending the HIV epidemic and continue to advance what is such an important program that we're discussing today. So now I want to pass the virtual mic to Dr. Laura Cheever, the Associate Administrator for the HIV/AIDS Bureau at HRSA.
Thank you. Next slide, please. So in HRSA, in the HIV/AIDS Bureau, we administer the Ryan White program that provides services to over half of all the people living with diagnosed HIV in this country. And we have been able to, the funding that we received for the ending the HIV epidemic, we were able to get out at the very end of February. We were able to support 47 of our cities and states that are in the focus areas of the first 5 years of this initiative, as well as providing funding for technical assistance and system support, and for all of our AIDS education and training centers program for workforce capacity, since we know that's going to be a critical part of what we do. Next slide, please. In the Ryan White program, we've been very successful among the people that are in care. We have 87% of people that come into care at least once are virally suppressed. So our recipients really do a remarkable job. That said, there are still 13% of people that come into care who aren't virally suppressed, and we need to make sure we are able to reach them. We haven't done what we need to do yet to reach those people or provided the supports we need. So that's definitely one of the 3 areas we're working on. Second, among the newly diagnosed, we know that that is a very precarious time for some people in terms of really getting engaged in care and feeling comfortable and welcomed in clinical services. So we're working to enhance those linkages. And finally, the third area that I think is the most complicated challenge for us are those people who have been previously diagnosed and are not in HIV care. We estimate that's about 250,000 people in this country, and we need to figure out how we do things differently to reach them. And we know that many people around this country have some incredibly innovative models to reach those that we are not currently reaching in many programs. And so we're spending quite a bit of time and energy making sure that we can really understand what those innovative models are that are working and spread them and disseminate them throughout the country. And that's a major part of our work. Next slide, please. We were very fortunate last year to be able to spend quite a bit of time in communities around this country, really talking to people with HIV and stakeholders about what they needed and what they needed to see differently from us. And on the basis of that, we were able to get funding from the Secretary's Minority AIDS Initiative funding to support 3 specific activities this year beyond the EHE funding. First is to provide a technical assistance around reducing stigma at the systems, organizational, and individual level, since we know that stigma, racism, discrimination, homophobia are really at the crosshairs of what keeps many people out of care. Second, to help our recipients build the ability to rapidly implement antiretroviral therapy, since that's a cornerstone of engaging people and even in re-engaging people as they come into care. And third, to focus on interventions and packages of interventions for Black women with HIV. As John and others alluded to, the COVID-19 pandemic has been a huge stress both here in HHS and the work that we're doing, but also in the health departments. As we're asking them to do new and different work with HIV, we're asking them to do it at a time that they're responding to COVID. However, looking across the landscape, really there are many things, and I think Harold mentioned this as well, new adaptations that occurred because of COVID that will really help us accelerate our EHE response. First is the adoption of telehealth. Harold was talking about for PrEP, but also for reaching people out of care. Many providers have told us, at least anecdotally, that being able to pick up the phone and reach people and have a visit by phone even has really significantly improved their retention rates. We are concerned about what this means in terms of the digital divide and what patients want and what patients' preferences are. So we're working on that as we start resuming normal operations in clinics. Second, which Harold mentioned for PrEP, but is also true for antiretrovirals, is many prescription plans and forms of medication coverage allowed people to get 90-day refills, which means they didn't have those gaps that are sometimes created at that 30-day mark, as well as increasing home delivery. And finally, the importance of self-testing, both for HIV and STIs, is something that I think we had wanted to do and had planned to do through EHE, but now we've really accelerated ourselves into it, and we want to be able to support and refine each of these 3 things as we move forward into EHE. Next slide. So with that, I'm going to turn it over to my colleague, Jim McCrae, who's the Associate Administrator of the Bureau of Primary Health Care here in HRSA.
Great, thank you, Laura. So glad to be a part of today's webinar, and of course, glad to be part of the Ending HIV Initiative. As Laura said, I'm Jim McCrae, Associate Administrator for Primary Healthcare at the Health Resources and Services Administration. If we could go to the next slide. Our Bureau oversees the nation's Community Health Center program, and what we're working to achieve through this initiative is to make HIV prevention services a routine part of primary healthcare in this country. And we're starting with many of the nation's most medically underserved populations. As you can see on this slide, there are approximately 1,400 health centers across the country. And these health centers operate 13,000 service delivery sites. And you can see it really is all across the country. These health centers provide care to nearly 30 million medically underserved patients annually. In terms of the patient populations, they serve 1 in 5 rural residents, 1 in 5 uninsured, 1 in 3 people living in poverty, and they serve a large number of homeless people, veterans, children in schools, as well as agricultural workers. If we can go to the next slide. We're building our expansion of HIV prevention services on a strong foundation in the Health Center program. And it really includes several key components. The first is around testing. In 2018, health centers conducted 2.4 million tests. That's a 50% increase in the last 3 years. Health centers also provide treatment for people living with HIV, nearly 190,000 in 2018, a 21% increase in the last 3 years. And nearly 600 health centers are providing PrEP. As Laura mentioned, in HRSA, we've been providing resources out to our grantees to help support the Ending HIV initiative. In late February, we awarded $54 million to 195 health centers in the target jurisdictions to expand outreach, testing, care coordination, and HIV prevention services, including PrEP. In fiscal year 2021, through the President's budget, we're proposing to expand this to the remaining 300 health centers that are in the target jurisdictions. We can go to the next slide. In terms of our model of care, it really is focused on 4 key components. The first is to conduct both outreach and inreach, basically get people into care. Next is to get them tested, which has been especially challenging with COVID-19, but like our colleagues, we've been encouraging our health centers to look at self-testing as a method to be able to get HIV tests done quickly and effectively for our patients. If a person tests positive, of course, the key is to get them into treatment, retained into care, and to reduce their viral load. And if they're HIV negative and it's clinically appropriate, to get them onto PrEP. We can go to the next slide. One of the things that we've done in support of the initiative is to really go out and listen and hear what are some of the challenges that will be going forward in the health center program to address this. I've had the pleasure of going on these listening sessions with Dr. Cheever, as well as many of my colleagues in CDC. Several of the themes that we've been asked to address, and we're asking our health centers to address more directly, is of course stigma, both in the community and honestly, sometimes in our own health centers. It's to engage non-traditional partners, including the faith-based community. It's to build workforce capacity from the front desk all the way through the care continuum. It's to help support community-wide efforts, recognizing that not just one program or one organization can really address ending HIV. And then finally, it's providing support and help to our patients to navigate the system and address any kind of cost concerns. What's key to that, of course, is PrEP navigators and supporting community health workers. At this point, I now want to turn it over to my colleague, Dr. Michael Tote in the Indian Health Service. Dr. Tote.
Thank you, Jim. The Indian Health Service serves members of 573 federally recognized tribes in 37 states. And the IHS joins our other sister agencies and HHS in this fight. At the end of 2016, an estimated 1.1 million Americans were living with HIV. Of those, 3,600 were American Indian or Alaska Native, and an estimated 1 in 5 don't know they have the virus and need testing. IHS data shows that nearly 350,000 Native patients between the ages of 13 and 64 were screened for HIV in 2019, resulting in a 31% screening rate. We're working to increase these rates, but we're also looking at ways to better screen patients who do not have or do not access a primary care provider. Next slide, please. CDC ranks American Indians and Alaska Natives 4th in the nation for the estimated rate of new HIV diagnoses when compared with all other races and ethnicities. According to the CDC, from 2010 to 2017, the annual number of HIV diagnoses increased 39% among Native people overall, but trends varied by age and gender. We saw a 54% increase for men and a 67% increase for those in the 25 to 34-year-old group. Most new diagnoses were among gay and bisexual men, accounting for 77% of all Native diagnoses. In the same report, the CDC also stated when compared with other people with HIV, Native people have lower viral suppression rates. For every 100 American Indians and Alaska Natives, 50% were virally suppressed. When we look solely at the IHS programs and data, we find more encouraging news. Our Phoenix Indian Medical Center operates an HIV Center of Excellence with over 300 people living with HIV. The program is working hard and showing results. In 2017, PIMC's HIV Cascade of Care demonstrated 93% adherence to care and 92% viral suppression for their patients. In fact, Native people who are living with HIV in Arizona have the best viral suppression rates of all racial groups in the state. Next slide. The IHS National HIV Program is highly reliant on minority HIV/AIDS funds. Last year, this fund provided $1.5 million to the Cherokee Nation of Oklahoma for an EHE pilot project. In the past few months, Cherokee Nation has instituted a texting service for HIV self-testing. They've enlarged their PrEP program and recently built up their capacity to offer PrEP via telemedicine. Finally, they've helped launch a national Indian country PrEP ECHO designed to train their physicians and physicians across the country to provide HIV care. We're working with IHS to launch a pilot program for HIV self-testing as well. Next slide, please. In addition to the Cherokee Nation pilot project, IHS, with resources from the Minority HIV/AIDS Fund, supports 9 of our 12 tribal epidemiology centers to conduct EHE efforts in tribal and urban communities throughout the country to diagnose, treat, prevent, and respond to HIV. The same funding source supports the National Native HIV Network, composed of boots-on-the-ground tribal HIV staff from around the country to promote the goals of EHE at the local level and advise IHS on the various HIV elimination strategies and challenges facing our Native communities. Finally, IHS supports HIV education and outreach through our partners at the Northwest Portland Indian Health Board, who operate social media and special youth projects, as well as the coordination and operation of Indian country ECHO programs with HIV care, PrEP, hepatitis C, and transgender affirming care. Because of our close partnership with HHS and tribal organizations, IHS is well on the way to reaching the goals of EHE and meeting unexpected challenges like COVID-19. Thank you for this opportunity. Our next speaker is Dr. Carl Diefenbach from the NIH.
Thank you, everybody. It's a pleasure to be here with you today. Next slide, please. Just to remind everybody, we're here talking about how we, as the federal partners, can operationalize EHE through the pillars. And the thing that we think about is what must we do differently in order to help us all achieve our goals of 75% reduction in new HIV infection in 5 years and at least 90% within 10 years. Next slide, please. So as we think about the cross-cutting nature of this initiative, what I've highlighted there for you is the role of NIH. We seek to inform HHS and our other federal partners in the best evidence-based practices and effectiveness. Next slide, please. Specifically, how can we work together with our federal partners, with the community, and with the local health departments to work locally to create solutions, to address gaps in practice, create partnerships, engage in training, consultation, and technical assistance, to implement scientific strategies, as well as to disseminate this information. Next slide, please. So here's some specific activities that we've been pursuing through our Centers for AIDS Research and AIDS Research Centers. We are continuing to expand team-initiated implementation science research. We are working to implement new programs to reach at-risk cis women with PrEP, evaluating and developing data-driven messages and communication strategies for EHE. Moving forward into fiscal year 2021, we do intend to hold a meeting to discuss these activities in January. Probably will be a locally virtual meeting to discuss the process and progress made from the 2019 awards. We will continue to establish partnerships and continue existing ones with CDC and HRSA to evaluate our activities within the 57 jurisdictions. Next slide, please. And with that, it's my pleasure to turn the podium over to Dr. Kirk James, Targeted Capacity Expansion, HIV Program Coordinator for SAMHSA. Kirk.
Thank you so much. This is working like a well-oiled machine, I'd say. I am stepping in today for our Chief Medical Officer, Dr. Niraj Gandotra, and it's certainly my honor to be here as a panelist on this inaugural meeting. I just want to point out some things that SAMHSA is involved in and working towards ending the HIV epidemic, just as our fellow federal agencies. You'll see here, if you turn to the next slide, on this slide, I just want to point out for SAMHSA, and some people sometimes don't see the immediate connection between dealing with behavioral disorders, substance use disorders, and mental health, how that connects with HIV. As indicated here on the left hand of the slide, you'll find that HIV, HIV/AIDS, substance abuse disorders, and mental disorders certainly work together in a very complex fashion, if you will. Where one can certainly act as a catalyst for the other, having a negative impact on HIV/AIDS, contracting HIV/AIDS, as well as spreading HIV/AIDS. One of the things I want to point out as you look at the right side of the slide is where we find a gap when it comes to services. Of the 330 million people in the US, almost 20 million or 19.7 million, looking at that first bar graph, are individuals who have a substance use disorder. And unfortunately, a very large percentage of those individuals are not receiving substance use disorder treatment. You see 92.3%. And as you follow this graph along and looking at other behavioral health disorders, looking at mental health, we also find a gap there where some 46.6 million individuals with mental health disorder, any mental health disorder, illness, some 57.4% of those individuals are not receiving treatment. And you can pass on, moving on to the serious mental illness, co-occurring disorders, where we talk about any mental illness along with substance use disorder, and you still find a very large percentage, of large gap. And the reasons for this are many. Sometimes it has to do with costs. Sometimes people being unaware that they have even a mental illness or substance use disorder, or may simply be in denial. So this is certainly something that SAMHSA is working to address, especially given the connection between substance use disorders, mental health, and HIV/AIDS. Another thing I'd like to point out, and we'll stay on this slide for just a moment, but just some important numbers I'd like to put out there. Our National Survey on Drug Use and Health, which we refer to as NSDA, is a national survey that deals with substance use disorders. And we found some impressive findings as we talk about HIV and substance disorders. So bear with me as I read these numbers to you. 7.4% of the overall US population 12 years of age or older have a substance use disorder. And then you compare that with 22.7% of those living with HIV. So you see the change there. When we look at illicit drug use disorders that are present, 2.8% of the general population have illicit drug use disorders. And that's compared to a much higher percentage of those living with HIV/AIDS, which is 14.5%. If we move and talk about specific drugs, methamphetamine prevalence being at about 0.3% for the overall population, but we look at individuals with HIV/AIDS, that number increases to 5.1%. And then lastly, one other drug I'd like to mention, cocaine, which is at 0.3% for the general population, and then is increased to 5.8% when we talk about individuals with HIV/AIDS. Now, what's equally disturbing is outside of substance use disorders are mental disorders, where the trend is really equally concerning. When we talk about the general population, 18.6% of the general population have a mental illness when compared to 37.7% individuals with HIV. When we talk about serious mental illness, 4.4% of the general population experience it when compared to about 8% of the individuals who have HIV/AIDS. So you see the trend there being much higher percentages of illness when we talk about HIV/AIDS. If we can move to the next slide. So here, what you find here is we talk about SAMHSA's programs, some of our discretionary programs, which focus on HIV/AIDS. Primary goals, as you can see here, are really threefold. One is to reduce the incidence of HIV infections, new HIV infections. The second, to improve HIV-related health outcomes. And SAMHSA is certainly cognizant of the health disparities that are present in our healthcare system. So we want to certainly reduce HIV-related health disparities for racial and ethnic minorities. Some of the programs within SAMHSA, if you're not familiar, there are three major centers: the Center for Substance Abuse Treatment, which I'm a part of, CSAT, the Center for Substance Abuse Prevention, CSAP, and the Center for Mental Health Services. And what's listed here are some of the programs which focus particularly on individuals who are at risk for HIV or who have HIV and have a combination of, may have also substance use disorder as well as a mental health disorder. So you can see some of the programs listed there. We have a program that focuses on minority women. We have a program that focuses on other populations who are at a higher risk for HIV/AIDS, in addition to being individuals who have substance use disorder. And then turning to our prevention centers, the CSAP, you see two programs, very important programs that deal with navigation and the importance of navigating the healthcare system, individuals who have a substance use disorder and may be at risk for HIV/AIDS. And then there's also the capacity building initiative. And then finally, our Center for Mental Health Services has a program which talks about service integration, which is very important. Obviously, we're talking about co-location of services, integrating services, and really treating individuals in a holistic fashion. If I can move on to my final slide. And here, final slide, really what we're talking about here is we're excited, SAMHSA is very excited to talk about a new guidebook that's going to be coming out. And this guidebook comes out of our National Mental Health and Substance Use Policy Laboratory. As you see here, this guidebook is entitled The Prevention and Treatment of HIV Among People Living with Substance Use and Mental Disorders. And it will focus on some of the things that have already been mentioned here as PrEP, pre-exposure prophylaxis, syringe services programs, some evidence-based practices, including cognitive behavioral therapy, contingency management. And then we'll also emphasize the importance of intensive case management, patient navigation, which was mentioned earlier, and then clinical coordination, as well as peer support services, which are found to be very helpful in addressing individuals with substance use disorders who may be at risk for HIV. And then lastly, I wanted to point out that we certainly approve of oral testing when it comes to the HIV, emphasizing as probably be better for a lot of our behavioral health organizations to implement oral testing when it comes to HIV testing. And then one of the things that has been added more recently is allowing our grantees to purchase self-testing HIV testing kits as well as hepatitis testing kits, given the climate that we now are dealing with COVID-19, where a lot of our discretionary grantee programs are not able to have face-to-face interaction, and then not to having being able to do the HIV testing face-to-face. So that allows an opportunity for our grantees to continue to test individuals who may be at risk for HIV. That brings my time to a close, and I'd like to pass the virtual mic, I guess, back over to Harold Phillips.
Thank you, Dr. James, and thank you to all of our presenters. And a special thank you and appreciation for all the work that you've done over these past few months to really be responsive to the needs and making changes at the federal level and figuring out how to support recipients and people at risk and those living with HIV. So I commend you all. It was an extraordinary effort, and I know that we will continue on this journey, as Admiral Giroir said, and we'll continue to look for other ways to make life simple in these times and also ensure that there's continuity of both prevention and care services. So we have a couple of questions in the chat box that we'll get started. I will let you know now that we probably won't have time to answer all of the questions. We will collect them and then develop written responses and post them on hiv.gov in the upcoming weeks. So I will start with some of the earlier questions that came in. And the first question is, let's see if I can find it again. The first question is really about the U.S. Preventive Task Force. I'm sorry, yes. How will the USP STF PrEP A recommendation impact availability of PrEP for patients with insurance? Dr. Merman, do you want to take that one?
Sure. I mean, I would just say that hopefully it will impact considerably. There's, I think what Mr. Shore is highlighting is that there's requirements in law that services that have been rated as an A or B by the U.S. Preventive Services Task Force are covered with no copay by most public and private insurers, and that could help a lot to make PrEP services more easily available, because reducing as many obstacles as possible can increase use. There is another question that in the series of questions that also highlights an issue for PrEP access, which is that there are other ancillary tests that are also recommended by CDC for PrEP use, including STDs. And it's important that those tests also be covered by insurance, because otherwise they can be an obstacle to continuing on PrEP. But there is some expectation that PrEP will be even more easily accessed when the task force's recommendations are incorporated into practice.
Great. Thank you. Thank you for that. Our next question is about the issue of housing and the long wait time to get people on and into housing programs. I'll start, and then if Rita is still on the call, maybe she would chime in. We definitely know that there are not enough housing resources to meet the demand. We hope that by providing the HOPWA resource tool, as jurisdictions think about using other resources for housing, such as EHE or the Orion White funding, that they'll take into consideration and have a picture of the HOPWA landscape. And then there is definitely a need to look at the other HUD programs which can help meet the needs of people living with HIV. Rita, anything else that you might want to add to that I might have forgotten?
Harold, I think you're absolutely right that we all recognize that there's certainly a need for more housing resources. And we have seen the HOPWA appropriation increasing in recent years. Not that it's meeting all the needs, but we have been experiencing that. And as you pointed out, I think it's really important, knowing that resources are limited, to make sure that we're maximizing what's available through Ryan White and possibly other sources like other HUD funding. And currently, we're also looking at that through the CARES Act funding, to make sure that we're coordinating on those kinds of resources as well.
Okay. Thank you. Next question, where can we access the data regarding the most recent HIV numbers and reductions? Dr. Berman?
Sure, I actually answered that question online with the direct URL to the CDC HIV surveillance reports, but also it's quite easy to just put in CDC HIV surveillance reports, and they'll come up with a web page that has all of the current reports, which can provide updated information. I'll also put a plug-in for the EHE dashboard that will be coming soon, and that will actually provide even more kind of current data on some of the indicators for EHE for the jurisdictions involved.
Thank you. Next question, could you provide a list of certified labs that provide the mail-in HIV/STI self-sampling kits? Also, do you have a list of certified virtual PrEP providers? So, a list of the certified labs that provide the mail-in HIV/STI self-sampling kits. I think that those labs would probably vary state by state, I would imagine. Is there anyone on the panel who wants to chime in on this one? That it may be better to check with the local and state health department on the certified labs, if I'm reading this correctly. Okay. So the next question is, and we may get back to that question and provide a more comprehensive response in writing. The next question is, there have been a few similar questions regarding older adults and long-term survivors and access info. So with regard to older adults and HIV and long-term survivors, this is an issue that we are very aware of, and there have been a number of meetings, discussions, and really working to understand the needs of long-term survivors and some of the challenges that are faced. And as EHE is a federal program that is implemented locally, I would encourage folks to be involved in the planning process and ensure that as we think about those who are older and living with HIV and have challenges staying in care, that we look at what innovative approaches or programs could be implemented at the local level to address some of these specific needs. Another question that or several questions have come up regarding the HOPWA webinar. The HOPWA webinar on July 23rd is specifically for EHE planners. So those involved in the EHE planning process at the jurisdictional level. The HOPWA resource tool will be made available, but this webinar is specifically for those jurisdiction planners so that they can understand the tool, how to be clear on how to use it, and also think about how they're going to roll it out on the local level. So it is a very targeted and specific webinar. The next question, one of my favorite questions. What is the difference between EHE and the National HIV Strategic Plan? So there is a difference. They are related. EHE is an operational plan implemented by various agencies within HHS to move toward ending the HIV epidemic. The National HIV Strategic Plan is the nation's plan for controlling and ending the HIV epidemic and includes other agencies within the federal government, but also our state and local partners and communities and civic organizations and the business community, and really thinking about how do we use the tools and the resources to truly end the HIV epidemic. So EHE is more of an HHS plan that relates to the national HIV strategy. And the two hang together very well. When the strategy is released, you will also see an overlap between the EHE indicators and the indicators that we will be using to track our progress for the National HIV Strategic Plan. Is there a place or a website where we can see some of the innovative ideas being used to reach and re-engage people who are not in care or have been out of care? I'm going to ask Dr. Cheever if she wants to take that one, maybe even talk about the Ryan White Compendium of Best Practices, which there's a lot of excitement about that as well.
Great, yeah, thanks very much. That's exactly right. So if you navigate, you put in Target HIV in your web browser, you'll come up to the Target HIV website where we have a lot of information and innovative practices listed there. We are specifically developing a compendium that'll be much more streamlined and easier to use and more searchable, and that'll be coming online soon. But there are quite a number of promising practices there, including guides on how to implement practices that have been demonstrated through SPINs and other initiatives.
Mm-hmm. Great, thank you. This question starts with a statement. We need to make sure telehealth reduces health disparities and does not increase them. Any thoughts on how to ensure equity? So there were some conversations as we were rolling out some of the new telehealth policies and the implementation of telehealth. We recognize the fact that it doesn't work as well in some rural areas due to infrastructure issues and internet capacity. We're also aware that with some folks being unfamiliar with the technology, or in some cases frightened of the technology, or not understanding it, that it also creates some inequities. I think this is something that we're all thinking about and looking for solutions to that and different ways to approach it. I do think that giving telehealth as an option, there are those patients as well as healthcare providers who are embracing it and loving it. And I'm always in favor of, if we can provide more choices so that individuals can access healthcare on lots of different fronts and in ways that are comfortable and supportive to them, then that's a win for us. So while telehealth may not work for everyone, it does work for some populations, and I think we'll continue to evaluate this and look as we move forward. What is the role of ER in testing? They may identify more people than home testing during COVID. They can also test HCV and STIs and even offer rapid ART. Dr. Merman, do you want to take that one?
Right, sure, and I know we're running at the end of the time, but I would just say that there's a great role for emergency department screening. And as the person mentioned, it's cost efficient. You know, if you have blood drawn for cholesterol, hemoglobin A1C, CBC, anything else to add on, either HIV or as they mentioned, hepatitis C, screening, it makes a lot of sense and has been shown to be cost saving. There has been reductions in visits to emergency departments over the past few months, and in a preliminary look seems to indicate that in the hospitals that still had a program for screening, that screening is still occurring, you just have fewer people coming in. And so that does mean that some people are not getting the screening that we would have hoped for, as well as wanting to expand that. So at the same time, we have issues of testing and kind of routine testing for people at increased risk, where CDC guidelines have recommended at least once a year, and for some people even more frequently. And for those people, going to the emergency department repeatedly isn't really the kind of the programmatic best practice, but it is accessing the test through other means, either their normal the community health center, their primary provider, or through potentially home tests. And so that, as at the current time, the only FDA approved home test for STIs, Hep C, or HIV is for HIV. And that does limit some of the ability to do more home testing. I would say that I think many people on this webinar have kind of appreciated the benefits for the American public of expanding the ability to get self-testing done, especially during this time, but even into the future. And I know of a number of companies that are thinking of moving more into that area that hadn't previously. So it's a dual approach, and if we do both of them, it'll help EHE move forward.
Thank you for that. So, as I said earlier, we will not get through all of the questions on this call. We will definitely capture them and develop written responses, which you will be able to find on hiv.gov, but give us a little bit of time to do that. Once again, I want to thank all of our presenters today. I also want to thank those of you that are out there in the field on the front lines doing this work during this very challenging time. I hope you have a sense from all of the presenters and from Admiral Giroir and myself that EHE continues to move forward. HIV is still a national priority. Our work right now is hard, and it's okay to acknowledge and say that it's hard, but also knowing how the HIV community has come together over the years to overcome different challenges. I know we can come together and overcome these challenges now. I want to thank you all for your continued efforts to ensure that HIV programs continue. On our next slide are some of the upcoming EHE events. And before we go, I also want to remind you to complete the evaluation and to please follow the hiv.gov blog for a summary of both today's session, a link to the slides, and also being subscribed to hiv.gov is a great way to stay up to date and be part of the EHE listserv and get future updates from us and from other federal agencies and also on the local level as folks do this work. Thank you all again, and please be safe and stay well. Thank you.